Hi, I'm Dr. Akturk from University of Colorado Barbara Davis Center. Today I'll be talking about the prescribing and educating patients with type 1 diabetes on the use of rapid and inhaled insulins. So this is my conflict of interest slide. I do research with multiple companies through University of Colorado. So first of all, if we start with the glycemic management, this is a very important study from the type 1D exchange that all you may know. Despite that, the advances in technology and therapeutics in the recent years, we are using better insulins, we are using better CGMs and pumps. Unfortunately, we are not achieving the targets for the glycemic goals, especially in younger ages. You see that difference is significantly higher. And if you compare with the 2010, 2012, and the 2016 and 2018, the A1Cs, you see the difference that unfortunately still the only 21% of adults are achieving the ADA goal of A1C less than 7, and only 37% of the adults are achieving the A1C less than 7.5. The average A1C increased from 7.8 to 8.4. So definitely we need to do better and in terms of the glycemic management. So how about the postprandial blood glucose? And then achieving postprandial glucose, the time and range is even harder. So we know the importance of the postprandial glycemic control. So, there are a couple papers and debates. Should we focus on the fasting blood glucose? Should we focus on the postprandial glucose? And this, even though this many years, the papers, and I will just go a little bit more in deep in the following slides, that they were done with the finger stick in the years ago, but they still show that the importance of the postprandial glucose. And now we have other tools, even we use for the other types of diabetes, like type 2, like the GLP-1 and the GIP-1 analogs that we use. These are the hormones that are very important also in the type 1 diabetes management. The GLP-1 slows the gastric emptying, and on the other hand, more rapid gastric emptying increases the GLP-1 and GIP secretion. So the GLP-1 and GIP increases insulin, and GLP-1 suppresses the glucagon. So more rapid gastric emptying increases postprandial glycemia, and acute hyperglycemia slows the gastric emptying while hypoglycemia accelerates it. So it shows the importance of the timing of the insulin administration, and insulin action can be challenging. In patients with type 1 diabetes, how an insulin fast and how effective is the key to control the postprandial glucose. If you consider that these people are also eating higher amounts of protein, higher amounts of fat, and sometimes higher glycemic index of the carbohydrates, and the timing of the insulin is the key. So the effect of the postprandial glucose on the A1C, that was the study that I was talking about in the previous slide. That if you look at this slide, that in this study, they studied that what is the effect of the fasting blood glucose and the postprandial glucose in patients in different A1C categories. If you look at that, on the right side, people are relatively in good control, less than 7.3 A1Cs. 70% of that glycemic load is coming from the postprandial glucose. On the other hand, if you look at the people are relatively worse control comparing to others, that 70% of the glycemic load is coming from the fasting blood glucose. So this study, shows that if you want to achieve an ADA target A1Cs is less than 7, that you need to really focus on the postprandial blood glucose, especially because in the higher A1Cs, you probably need to increase your basal insulin a little bit more. But when you're trying to get a little bit more strict, and that's the postprandial glucose is the key for a better success. So the common problems that we are having with our patients with the insulin injections, that the engagement and involvements, especially in some younger professionals, people are, college students, or people are new to diabetes. So the engagement and involvement is a big problem. So we can just need a little bit more education for these people. And injection technique problems. In my clinic also, I see people that many years they are giving insulin, but unfortunately they are either, not accurately injecting, or they are injecting to the same site, or they are just removing the needles too early. And the lipohypertrophy is a major issue that unfortunately many clinicians are missing. So lipohypertrophy is this fat deposition underneath the skin. If you give the insulin injection at the same location all the time, most of the time I see on the left lower side, because most of the people are right-handed and they are giving the injections always on the same location on the right side. So that's a bigger problem, that lipohypertrophy causes insulin absorption issues and the fluctuations in blood glucose. And needle anxiety. There are many patients that are trying to choose the needle size, and even though some of the needles, and they say this insulin is burning, or this insulin, a little bit causes issues. And also social stigma that causes a lot of barriers for the young individuals. And the timing of insulin, as I mentioned again, and I just would like to highlight this again, it's very important. Even though you just make a perfect carb counting, but if you are not giving your insulin in a timely manner, your blood sugars will be high after that meals. And the carrying and traveling with the needles, this is always an issue. The people are getting a lot of stress in the airports, or carrying a lot of insulin supplies, the cold chain and everything. And fear of hypoglycemia. Most patients, unfortunately, tend to underdose, or try to give a little less bolus before meals. And they say, I don't know how much I will eat. Let me give a little bit later. Let's see. And then there is a huge postprandial blood glucose increase. Then it takes a couple hours to go down. So it unfortunately affects the A1C and the time and range. And there are many young individuals, and some also any age can miss some of the injection boluses too. So how do we classify the insulins? 20, 30 years ago, they named that insulins compared to insulin are that rapid insulin analogs. But right now we have faster insulins. So how do we name this? So it's kind of a challenging situation. If you are calling insulin lispro, insulin aspart, insulin glulisin, the rapid insulin analogs, then you may need to call the others and ultra rapid insulin analogs. However, that these ultra rapid insulin analogs are not as fast as between each other. So they are actually very different. Insulin lispro-aabc, fast acting insulin aspart, and are actually slower than technosphere insulin, that I will go in details a little bit more. So if we start with the fast-acting insulin aspart, that the FIASP, and actually this is a insulin aspart, exactly the same insulin molecule, added with vitamin B3 and L-arginine. So these are the two molecules that basically in the ingredients, that vitamin B3 increases the absorption, and L-arginine is the stabilizer that helps to absorb a little bit faster. If you look at the PK and the PD of this insulin, you see that a little bit faster, about 11 minutes at the onset and about 35.4 minutes, and then when it's done. But the effect of the insulin is relatively the same, that you see the tail about goes up to 300 minutes. If you look at the PD, it looks a little bit more similar compared to the comparator insulin aspart, but this can be a little bit slightly fast. But how about the studies? There are many studies that are onset 1, 2, 3, and it's going like that. And all the insulin aspart studies check the postprandial glucose and the effect on that inferiority or superiority and the A1C in duration in the 26 weeks. So what they did, they compared insulin aspart given in the mealtime and the faster aspart. You see on the left side, and you see that in 1 hour and 2 hours, that better postprandial glucose achieved in the first 2 hours. But if you see that after the 3 hours, it's kind of, and the 4 hours is getting exactly the same. And so you have a 2-hour window that gets actually a little bit more beneficial. On the other hand, they also looked at if we give after the meals the faster aspart, but if we give the comparator insulin aspart at the meal time, you see that actually that faster insulin aspart, if we give after the meals, actually doing worse in the 60 minutes, and there is no difference after that. So it still shows that even though we call this fast-acting insulin aspart, it's not as fast as we think, that you still need to give before meals or at the same time, but not after. Otherwise, actually, you do worse compared to the insulin aspart. And in this long-term study with the 26 weeks, the same thing as compared with the insulin aspart mealtime, faster aspart in the mealtime and post-meal. And if you see that significantly higher the faster aspart post-meal A1Cs, and there was no difference significantly for the A1C in between the insulin aspart and faster aspart in mealtime. It met the non-inferiority criteria for FDA, which means that your A1C improvement was less than 0.4%. So it's getting an FDA approval for the non-inferiority claim, but it was not superior. And none of the studies, except some sub-studies that's actually sub-analysis in a small amount of picked people, that you can see that actually there is a time in range and A1C improvement. Otherwise, there was no time in range and A1C improvement, any onset study. So if we go to the insulin lispro-aabc, which is the Longev, and you see that is exactly the same molecule, insulin lispro, and added some other molecules to increase the absorption, such as treprostinil, which is a prostacyclin analog, causes some local vasodilatation, and they added a citrate, and it's enhancing the vascular permeability. And if you look at the PK and PD of this molecule, if you see that a little bit in the onset is a little faster, but different from the other insulin that I showed you, that faster acting insulin aspart is a little bit shorter and less tail compared to the comparator. And the PD is a little bit different than the previous ones, and it's a little bit, goes up a little faster and goes down a little faster too, compared to the faster insulin aspart. If you look at the studies, are done in the same design exactly that I mentioned, that in comparator insulin lispro, they are giving at the mealtime, and then giving the mealtime faster, lispro, and also the post-meal lispro. And you see that at the beginning, it's a little bit better, but giving after the meals actually makes things a little bit worse. And the same thing for the A1C benefit, it meets the non-inferiority criteria, but unfortunately, in the Pronto type 1, Pronto pump, Pronto pump 2, and none of the studies, unfortunately, didn't show any improvement in the overall time in range and A1C, except some subgroup analysis in some patients. So if we compare the ultra-rapid acting insulins with the circulating endogenous insulin, if you see that inhaled insulin are the closest one in terms of action, and injectable ultra-acting insulins, that the two of that I mentioned, actually they have a longer effect and more time to peak and more time to a measurable effect in terms of action. So the common problems with the injectable ultra-rapid acting insulins with the fast-acting aspart and the lispro-aabc. So in both the onset and the Pronto studies show that injection and infusion site reactions are common, and the redness, pain, itchiness, and some of the pump studies in this insulin show that there are some occlusions happen in some insulin pump models that are commonly used. And on the other hand, high cost and insurance coverage problems, sometimes insurances are not covering, and they are a little bit more expensive than the comparator insulins. And that's also another common issue for the other type of insulins, unfortunately. And no effect on the A1C at 24-hour time and range in major clinical trials that I mentioned earlier already. So they are not superior to rapid insulin analogs. but not inferior. They are meeting the non-inferiority criteria, but they are not superior. So how about the inhaled insulin? So inhaled insulin is a technospheric insulin is absorbed through the lungs without having to change the molecular structure, and it passes through the subcutaneous tissue or undergo first pass metabolism. So because it bypasses these routes, it's just absorbed so quickly. And it's a monomeric insulin diffuses into the systemic circulation more rapidly than their larger counterparts. If you look at that, the comparison here, that ultra-rapid acting insulin pulmonary delivery is actually less than 1 minute after the inhalation. And if you look at the rapid acting insulin delivery, it takes 5 to 15 minutes to reach a level. And the long acting insulin is actually 30 to 60 minutes because they are actually a bigger structure. And if you look at the inhaled insulin, how that's the mimics the endogenous insulin that is previously I also showed in the numbers too. If you on the left side, you see this adults without diabetes, and this is like a normal human physiology. You see that when there is a carb intake, that's the pancreas's response with a rapid, increase in the insulin, then it's kind of slowing down in action. If you see that in the purple line here, that compared to the insulin lispro injection, you see that how it's fast goes up and then goes down a little bit faster compared to the insulin lispro. You can ask this, why this is a 12 units of inhaled insulin they compared with the 8 units insulin lispro. And I will just talk about a long time about this one, the doses, that because the inhaled insulin doses are not equivalent on the injectable insulin doses. So if you look at a little bit more about the inhaled insulin studies, and for example, that's the beginning of the AFFINITY studies, the AFFINITY-1 inhaled insulin study. So that was a non-inferiority study for 24 weeks. And in people with type 1 diabetes, an A1C between 7.5 and 10. And between group difference, A1C was 0.19% at the end of the study. So just as a reminder, again, FDA non-inferiority margin is 0.4%, as I mentioned in the previous studies too. So it less hypoglycemia, it caused less hypoglycemia, less weight gain, and in the inhaled insulin group. And 5.7% of the patients in the inhaled insulin group discontinued the medication due to cough. And less people, on the other hand, achieve A1C less than 7 with the inhaled insulin group. And we can explain this with the action of the insulin, because it just appears in the bloodstream so quickly, and it also done in 2-3 hours very quickly. So if somebody's eating a little bit higher carb, may need some additional insulins. And then you see that it was over 170 patients are compared in this study. So if you see that what we learned in the affinity study, that actually that we may need some additional boluses in that with the inhaled insulins, that actually because there are advantages of the inhaled insulin that it's so quickly, and it's also an advantage and disadvantage. It also disappears from the bloodstream so quickly. It causes less hypoglycemia. There is no tail of that curve I showed you, that these are all advantages. But on the other hand, if you're eating a little bit more carb or a little fat or protein, you may need some additional insulin. So that's an investigator-initiated multi-center study, is a 4-week study that all patients used the CGM during the trial for 4 weeks, and all adults and about 60 patients in 4 centers with the type 1 diabetes. So we compared the inhaled insulin study comparison to the insulin aspart injections. And the inclusion criteria was A1C between 6.5 to 10. So we compared the 26 inhaled insulin users, the first-time users, and the 34, the control group. So, and the randomization was based on the A1C over 8 or less than 8. So what we did, you see on the left side here that type 1 diabetes dose conversion. So this is an FDA-approved label indication, because as I earlier mentioned in the previous slide, the inhaled insulin doses and the mealtime insulin doses are not the same. So because inhaled insulin comes with 4, 8, 12 inhalers, so up to 4 units, and then of the injectables, you take 4 units, 5 to 8, you take 8, 9 to 12, you take 12, and it goes like this. So we would like to add some additional doses as a correction if your blood sugar is less than 150, and at the 1 hour and 2 hours, you're not giving any additional insulin. On the other hand, if your blood glucose is higher than 151, so you give 151 to 200 additional 4 units at the 1 hour. And if it's more than 201, you give 8 units for the 1 hour. If still high, you can just consider giving another 4 units. So we want to see what's the effect of giving some additional doses after the meals. And as a reminder, all this inhaled insulin group already taking at the same time the amount of the insulin, converting from the whatever that mealtime injectable insulin that they are calculating with their carb ratio and giving as an inhaler. In addition, if their blood sugars are still high, they are giving an additional dose. On the other hand, the control group was told you can just do whatever you want. So we didn't force them to give any other doses, but we didn't tell them not to give any other doses. So they also were open to give some additional doses if necessary. So summarizing the study, you see that the orange line is insulin aspart, which is the comparator of in this study in the injectable. The blue line, the solid blue line, is the inhaled insulin, and with this all patients. And if you see that comparison of these ones, and then inhaled insulin all and insulin aspart are significantly different here at the 60 minutes. Basically, that are the inhaled insulin users has achieved significantly less postprandial blood glucose. And we also looked at in 2 different groups in this study, that in this solid blue line, we divided into where the people are taking this insulin, and according to the correction protocol that I showed here, that additional boluses are they taken, and according to the protocol, insulin taken is considered more than 90% of the time. At least 1 supplementary dose is taken after the meals. On the other hand, there are some patients didn't take any additional insulins despite they are in the inhaled insulin group and they were suggested to do so. And so they less corrections and then the protocol, and you can see this in this black line. And if you see that for the here 60 minutes, 90 minutes, and 120 minutes, we're comparing the taken inhaled insulin according to the protocol and the insulin aspart, which is a comparator group. In this first 2 hours, is a significant, statistically significantly postprandial glucose is better actually in patients with type 1 diabetes using the inhaled insulin. So if you continue with the study results, that you see this orange bar here is the comparator group with the subcutaneous insulin. The purple bar, you see that the inhaled insulin not taken according to the protocol, the underdosed, and you see that this blue bar is the inhaled insulin taken according to the protocol. Is a significant differences are comparison between this people are taking and not taking according to the protocol versus also according to the protocol and the comparator group. And the time in range significantly increased from 53.8 to 62.45. And there are 2 more hours in time in range in inhaled insulin taken patients. Again, the definition of the according to the protocol was taken more than 90% of the time, at least 1 more supplementary dose. And time in hypoglycemia was actually less in the inhaled insulin group, 2.2% compared to 3.8%. So if you look at a little bit more for the postprandial glucose with the different meals, the postprandial glucose excursions were an inhaled insulin as recommended compared with the aspart group at breakfast and lunch were significantly better compared to dinner. In the orange bar is the subcutaneous insulin, and this blue bar was the inhaled insulin taking according to the protocol. If you see that these people are actually trying to underdose for the dinner meals significantly compared to breakfast and lunch, and they got the better achievements for the breakfast and lunch. And we consider these results because it's very interesting. So it comes with how that actually the labels of the inhaled insulin and how the packaging. As I mentioned, it comes with 4, 8, 12 inhaled insulin units, which on the other hand is not the equivalent of the injectable insulin. So people tend to underdose for the dinner because they were never taken like 12 units, 16 units, 20 units of insulin at any time. Actually, it's actually almost half the equivalent of that injectable insulin. So, and was the main problem. And I will go a little bit more in the following slides about this dosing conversion and other confusions that the patients are having. So in the AFFINITY-1 trial, if we look at the hypoglycemia perspective with the inhaled insulin, as I mentioned in the study, there was no, the hypoglycemia was less in the inhaled insulin group. And if you see that in the level 1 and level 2, which is less than 70 and less than 54, the hypoglycemia results were significantly less in the inhaled insulin group compared to the subcutaneous insulin. And on the other hand, the level 3, the requiring external assistance for recovery, that the severe hypoglycemia were not different. So how about the postprandial hypoglycemia in the AFFINITY-1 trials? And if you say that less hypoglycemia with inhaled insulin after 2 to 5 hours after the period of meals. And if you look at that, the orange bar, the subcutaneous insulin, the dark bar shows that more than the 2 to 5 hours after the meal, and the light bar shows the first 2 hours. And if you look at that, the blue bar is the same for the inhaled insulin. The darker side is showing that after the 2 to 5 hours, and the light bar shows the 0 to 2 hours. You see that less hypoglycemia with inhaled insulin after 2 to 5 hours here significantly, because as I mentioned, inhaled insulin is in and out in the 2 hours most of the time in the smaller doses, a little bit in the higher doses, maybe up to 3 hours or so, but it's actually in and out. So there is no tail compared to the insulin, aspart, and lispro. So it gives you a significant advantage for the late postprandial hypoglycemia prevention. So how about the change in the lung function with the inhaled insulin? In the clinical trials, up to 2 years, patients had a small decline in their FEV1, and this is about 40 milliliter. And there were no difference in between patients with type 1 diabetes and type 2 diabetes. And this is patients are over 1,500 patients were compared. And this is a temporary decline in the FEV1. Is after a while that you stop the inhaled insulin, it comes back, but it doesn't affect that in the clinical practice or anybody, assuming they have normal lung function before starting the inhaled insulin, that they need to be concerned about that. There are athletes and there are younger people and very active doing sports, so they can still are using also the inhaled insulin. So how about the FDA label and the safety precautions with inhaled insulin? And inhaled insulin is contraindicated in COPD and asthma patients, and the medical history, physical exam, and spirometry values to check the FEV1 and before the initiation is required. FEV1 measurements should be done before the initiation visit and after 6 months, and then every year. And you need to consider to discontinue if the FEV1 measurements are going down more than 20%. So starting the inhaled insulin, the anticipated inhaled insulin dose, as I mentioned, it comes with 4, 8, 12 units cartridges, and these are the colors in 4, 8, and 12. And then this is the FDA approved label here. You see that up to 4 units, you just round up to 4, 5 to 8, you round up to 8, 9, 12, 12, and it goes like this. But our post-marketing data and all this research show that this is actually underdosing significantly the patients that we are giving. And as you see in the study and even the other studies. And this, we anticipated the titration dose of inhaled insulin 1.5 times. If you do that, you see that even you can just upgrade to a little higher cartridges and you can use. And this is kind of more like a clinical practice and based on the studies that we learned that can be a little bit actually better. So there is a very recent study actually compared to 2 times dosing. And if you see that in this one is they compared the label dosing, which is rounding up to the higher number. And this is a 2 times, like one to two. If you are taking 2 units of aspart, you'll be taking 4 units of inhaled insulin. If you are taking 4 units of lispro, if you'll be taking 8 units of inhaled insulin. So 20 patients are compared in each groups, mostly type 1 diabetes. And then if you see that the postprandial glucose in the 2 hours for the dose 1 and dose 2, there's 2 times dosing group had better postprandial glucose excursions and without a significant increase in the hypoglycemia, which is actually shows that 1 to 2 dosing can be so much beneficial to cover that the meals after to achieve the better postprandial glucose achievements. And if you see that, especially that when you go to the 60th and 19th and 120th minutes, you see a significant achievements in that higher doses with the inhaled insulin. And that was, as I said, was a common problem as an issue with that the study, most people actually underdose their insulin, and because of that, the labeling, current labeling. So how do we measure the FEV1? As I mentioned, that you have to be checking at the beginning, you have to check after 6 months, and you have to check after 12 months. So the company is sending to do clinics and device that you can measure the FEV1, a small battery, with a battery, with a small spirometer, with a mouthpiece that you can change. So you insert the mouthpiece and switch the device on. You instruct the patients to exhale 3 times, and you record the best FEV1 results. And actually then send in the chart. So whenever the patient comes again 6 months later, and then every year, so you can just compare. If there is a decline more than 20%, and there is you have to discontinue the medication, which is actually in clinical practice is very uncommon. So how the patients know that are they, using this device properly, and then improving absorption of the inhaled insulin with the blue hail technology. And this is can be given by the company. You can get from your prescriber clinic, and you can just try that, or you can just use on your own a little bit. So this is a Bluetooth enabled accessory device that mounts onto the inhaler. So whenever you change your inhaler, you just remove this and put another one. You can charge this one. So it comes with an app and in the smartphones, and educates the patients on the correct inhalation technique and handling of the inhaler, and provides patient with a visual display of their inhalation length and effort in a smartphone app. You see that here, that is the patient's performance, which should be above this green zone. If this one is here, is touching like half, or is like going here, and it just tells that, you have to do it. And because you are just not, inhaling enough, or not inhaling long enough, or not inhaling, you have to inhale is a little bit more, powerful. So it just shows the length and how much you have to inhale that insulin to get an 100%, absorption of your insulin. So it's a great tool. And you don't need to use this every time you are using your insulin. I think at the beginning is our experience. If you just get used to this one, then you just learn what should be your duration, and then how you should be doing that. And then it just gives a good starting point and a guidance at the beginning. So if we go with a case study with one of my real patients. So I have a 24-year-old female patient. She's a primary school teacher, and she has type 1 diabetes for 8 years. No microvascular complications so far. And she uses 20 units of insulin glargine once a day. and uses 1 to 10 insulin carb ratio with the insulin aspart, and using a real-time CGM in last 1 year or so, and the last A1C is 8.6. So then we need to decrease this A1C a little bit more. And then when we were talking, she admitted that she's missing most of the boluses, especially at work. And because she's a teacher, no time to wait, 10 to 15 minutes for lunch at work, and she's surrounded with students all the time, and she's hesitant to use insulin pens at school, afraid of being, stigmatized by her students. And then it's actually a common problem for my teacher patients. That's not the only one that are missing most of the lunch doses at work. So if you look at that at the lunchtime, some of the days, and even some of the mornings, that she tends to actually not bolus at all. You see that, and or just bolusing sometimes late. And then you see that likely boluses here, because after the reaches to the higher numbers, and it just goes down so quickly after for a correction, and sometimes even missing the dinner doses too. So we started the insulin will be a little bit more discreet, fast. She can just do in a 30 second, and then she doesn't need to carry the needles. And then this is the 2 weeks of insulin aspart. You see that time and range is about 40%. And this is the same patient, 2 weeks with inhaled insulin. You can see about 48%. You can even see the decrease in the hypoglycemia from 3.5 to 0.7, because as I mentioned, because she waits to reach the steady, higher level, then she gives a huge bolus to decrease that, and it just crashes in the postprandial late glucose. As I previously showed in the studies, that inhaled insulin is actually doing so much better than the injectable insulin in terms of preventing the late postprandial hypoglycemia. So you see that even for like a 2 weeks, very short period of comparison, you see an improved time and range and less hypoglycemia. So if we summarize the inhaled insulin, that there are some advantages and disadvantages like everything. So, and if you know them, and if you know how to mitigate the disadvantages, I think it can be a great opportunity and tool. And for the advantages, and ultra rapid acting insulin, and it's an in and out insulin, faster than any insulin in the market, including that the faster insulin aspart and faster insulin lispro. So it achieves the better postprandial blood glucose and less risk of hypoglycemia in the first 4 hours, and especially even for the late hypoglycemia prevention after the meals. No needles, easy to carry and use. You still need to refrigerate the cartridges, but you can just carry with you if you are using for that day. Good for snacks coverage. You can use as a touch-on, if you are just eating a small snack, or especially if you are eating a late night snack, at 9 o'clock, 10 p.m., it can be a little bit advantage if you are going to bed around midnight. So you don't want to give like a 4-6 units of insulin aspart or insulin lispro injection that may cause some hypoglycemia in your sleep at 2-3 a.m. because of the duration. And you can be just take your inhaled insulin and it will be done, and 100% before you go to bed. So good for young adults and busy professionals, and sometimes they are missing insulin for different reasons, that it can be, as an advantage. And some patients, tend to use with a pump use though, even though it's not like in the, label use, and sometimes they use as a touch-on. And then ideal for patients they cannot wait 10 to 15 minutes to eat after injections. So possible disadvantages are requirement to start an FV1 measurement with a spirometer. So some of the physicians may not know that, even though it's so simple. And some of the, sometimes the follow-up for every 6 months at the beginning, then every year, maybe an, issue. So if somebody is eating high fat and protein meals, you may need some additional dosing. So because, as I mentioned, depends on how you want to see in and out action of the inhaled insulin. It's, it's very fast, but a shorter duration of action. Shorter duration of action you can use for your advantage and for your disadvantage. If your blood sugars are high after a high fat meal, then you have to give another dose after 1 hour or 2 hours. Maybe you may need a smaller dose again. And people tend to underdose, as I mentioned, because I believe the current FDA label is significantly underdosing. And the post-marketing, several studies show that I mentioned a couple of them, that at least 1.5 to 2 doses are needed, and that only available in for 812 units cartridges. If somebody wants to give a little bit different than that, it can be an issue. And the confusion about the dosing units, and we had this issue with the patients. So education is the key. People tend to underdose in fear of hypoglycemia, even though you need to tell them that very clearly, that these are apples and oranges. These are not the same thing. 4 units in insulin aspart are not the 4 units of inhaled insulin. So there are very different things. So there is no pediatric indication yet. So, and then that's another thing for the pediatric patients, but there is a large multi-center study is going on right now in United States in the pediatric population. And insurance coverage, sometimes you need to do a prior authorization and it may be denied again, and you need to work a little bit on that. And there are some special pharmacies are doing that for you. You may need to do wherever you are living or working. And as a provider, you may need to, search for that. If you cannot get anything, that companies, most of the times gives a program that, they give a little, duration of like a free insulin, and they try to do some paperwork. So insurance coverage is a problem for all of these insulins and all diabetes supplies and everything, unfortunately. So inhaled insulin is not immune from that issue, unfortunately, in the healthcare system. So my suggestions with clinical and research practice and for better results with inhaled insulin. So you need to know the PK/PD of the inhaled insulin. You need to know that this insulin is different than injectable insulin. So, you have to teach your patients that this insulin is different. So if you use this insulin as it is for your advantage, and it can be a great tool to control your postprandial blood glucose. I think the education is the key, as I mentioned, how you just use your inhaler, how much the dosing, and encourage to dose properly so they are not underdosing. So you have to identify appropriate patients for better results. You have to really get a medical history. If somebody has a history of COPD, asthma, any issues, and if somebody can use this carry easily, and then is okay to use this one, as a touch-on, and sometimes in combination with other, insulins, or sometimes alone for the to control their postprandial blood glucose. And you need to really explore your insurance coverage and discount options. That's unfortunately a big hassle for all of us in diabetes care and everything. So it's the same thing for the inhaled insulin too. But most of the time we find ways to get it covered, and the patients can, for a reasonable price, so they can get it. So following a plan for FE1 testing and those adjustments. For FE1 testing, your spirometer, you need to be in the room. You have to check it. You have to make a note. And for the 6 months later, and then every year, and after the initiation date, you have to check it during that where they are using. If they are using, as I mentioned earlier, if it's a decline that more than 20%, which is unexpected, then that's an FDA label says you have to discontinue the medication. But as I mentioned, there is a small decline is expected, about 40 milliliter or so. And the dose adjustments, I think that's the biggest, most important thing is the dose adjustment, is that the dose adjustment is you need to be sure that your patients are properly dosing the inhaled insulin, because it's not the same amount of the doses, and you have to escalate the dose a little bit more, and you can use up to 1.5 to 2, as I mentioned from the earlier studies. And most of the patients tend to underdose. So you have to really, if somebody is not happy, you have to really consider how much inhaled insulin that person is taking. So that's one of the most important things. So as I mentioned at the beginning of my talk, the postprandial glucose control is the key to achieve a proper A1C. Either you are using a pump or injection, so you cannot get a reasonable A1C less than 7 or 6.5 with ignoring your postprandial glucose control. So I just wanted to summarize all the options for that the patients are using injections to control their postprandial glucose. And that's the end of my talk. And thank you very much for listening to me. Thank you.